everyone. My name is Veronica. This is Ben. We're second year students at the Wayne State School of Medicine. We're co-presidents of LGBT People in Medicine, the student org there. So today we're just going to be talking about some of the health disparities that affect the LGBTQIA population and sort of what's being done in medical schools and beyond to combat these issues. So just looking at the scope, so the US population is about 326 million people, and of that, at least 12.4 million are LGBT. This is an underreported number. This may not include a large population of people, so either way around it, we're looking at a huge group of patients that are missing out on a lot of things because of healthcare disparities. So when you look at the AAMC website, they have an overview of health disparities affecting LGBT individuals, and this is what shows up, which is a lot and kind of overwhelming. So we're going to sort of break down some of the biggest things that the LGBT population is at risk for in terms of healthcare.
So the LGBT population has a lot of different risk factors that affect our healthcare. So 40% of homeless youth identify as LGBT. There's also lower cancer screening risks. So despite higher rates of tobacco use and alcohol use and other risk factors, lesbians are less likely to get certain preventative services. And also things like, so lesbians have a lower rate of pregnancy, but pregnancy actually acts as a protective factor against certain kinds of cancer. So we should be screening this population more. And then there are also higher rates of mental health issues within the LGBT population. And so we can see that approximately the rate of psychological distress and the rate of needing a medication for mental health problems is about double in the LGBT population. Almost half, or about half of transgender adults report contemplating suicide. That's 10 times the LGB population and 25 times the heterosexual population. And then LGBT youth are just much more likely to attempt suicide. So despite increased health risks, we're not seeing this patient population as much as we should be. So there's various reasons for that, from less health insurance coverage to the fact that LGBT adults are less likely to seek care when needed, more likely to delay prescription medication.
Okay, so now we know that the LGBT population is a big part of our patient load as healthcare providers, and they're coming with increased health risks for certain things like we mentioned, but they're not coming in. So why is that? One of the biggest barriers to healthcare access for LGBTQIA individuals is a lack of health insurance. This may be due to increased risk of homelessness. 1 in 5 transgender people have experienced homelessness at some point of their lives. Maybe due to unemployment. A vast majority of transgender people have been mistreated at work due to their gender identity or expression, so they may be unfairly fired and may choose to leave because of discrimination. So these lead to lack of coverage, but even if people are covered by health insurance, they may not be getting the coverage for certain things that they need. For example, gender-affirming medication and procedures are often not covered by insurance, and screening test coverage. I'll give the example of a transgender man who has legally changed his gender and name and everything, but still has a cervix. So he still needs pap smears and stuff like that, but the insurance company looks at his information and says, this is a man, he does not need a pap smear, and won't cover it. So even if these patients are covered, technically, they may not be getting the healthcare coverage that they need. So that's why they're not coming in. Also, there is a lack of competent providers. So this may be cultural competency. Providers who maybe don't know what it means to be LGBT, maybe don't know how to talk to LGBT individuals, haven't been, taught about these things. They don't know about the right way to go about risk factor assessment. So as we mentioned, there are some risk factors that we want to look at the LGBT population. And if physicians aren't aware of that, they may not ask the right questions about abuse, homelessness, obesity, cancer, STIs. We should be asking all our patients that, but having a better idea of what risk factors you want to ask about is always a good idea. And then it's also a matter of medical competency. So not being aware of screening needs. For example, transgender men may have a greater risk of ovarian and endometrial cancer if they're on hormone replacement therapy with testosterone. And that's not something a lot of people know. Medication needs and interactions. A lot of physicians aren't learning about the newer puberty blockers that are coming out and stuff like that. And 50% of transgender and gender nonconforming patients report needing to teach their provider about their healthcare needs, and that's a problem. And even if we do have physicians who are competent in all of these things, sometimes they're hard to find. So there are databases out there to help LGBT people find competent providers and LGBT-friendly providers, but they're pretty sparse and sometimes hard to navigate. So that's one of the problems that we have, is just a lack of visibility of physicians who can treat the patients. Okay, and another reason why patients aren't coming in, we know they have a lack of health insurance, a lack of competent providers, and there's also the fear of discrimination, humiliation, or misunderstanding. So about 70% of sexual minority youth do not discuss their sexual orientation with their doctor, and of that population, it's more likely to be bisexual individuals. So it's born out of this fear of discrimination.
So, to understand where this fear of discrimination comes from, we really do need to look at the past. Homosexuality was in the DSM, the Manual of Psychiatric Disease, until 1973. Gender identity disorder was in it until 2012. And then genital normalizing surgeries are still happening today, and often the patient might never, if done at a young enough age, if their parents don't tell them, they might never even know that they went through that. And then there's still, as much as people would like to hope that stigma against AIDS patients and HIV positive patients is resolved. It's very much from it. There is still a lot of stigma within the medical world as well. So we can see on the right that about 50 to 70% of LGBT patients have felt discrimination when receiving health care. And about 8% of gay patients and 27% of trans patients have been outright refused treatment. So a few other ways that people in the community have felt a discrimination. HIV positive patients have a very high rate of having providers refuse to touch them or use excessive precautions, pretty much make them feel unwanted, that they do not want to provide them with health care, or blame them with their health status. But when it comes to outright abuse, trans patients see a very high rate of both of verbal abuse and a significant rate of just physical roughness between shown to them by their care providers.
So we have this large population that's at risk for a lot of health problems like cancer, homelessness, STIs, mental health issues, but they're less likely to receive treatment due to a lack of health insurance, a lack of healthcare provider competency, and this fear and history of discrimination against LGBT patients. So let's talk about what the healthcare schools and providers are doing to sort of combat these issues. So the current state of medical schools in terms of LGBT healthcare education, about 7% of US medical schools report 0 time spent at all on LGBT healthcare in the preclinical curriculum, which is up from 50% in 1998, but we want to see that 7% go away. And of the schools that are teaching about LGBT healthcare, there are a third of them that report 0 time spent at all in the clinical years. So you may get a little bit of background before you go out into the hospitals, but then they're going out to the hospitals where they're starting to get practical experience, and that's never revisited, and it's sort of forgotten about. And then overall, there's a median of about 5 hours of LGBT curriculum content total over 4 years in medical school. And this is translating into how physicians feel about talking to their patients about sexual orientation and gender identity. In the survey that was done that asked providers, why they don't talk to their patients about these things, the top reasons were a lack of experience talking about these things, concern about making the patient uncomfortable, and being unsure of appropriate language to use, or concern about offending the patient. And that's, that can easily be remedied if they're taught about these things, whether this is in medical school, residency, while they're physicians. And it's hurting the patients because this ignorance from physicians is leading to conditions being undiagnosed. Doctors aren't able to educate their patients about risky behaviors or other mental health concerns. And there's just, in addition to all of that, there's just a general lack of data on LGBT healthcare out there. So, even if if physicians try to educate themselves on LGBT healthcare, they may not be able to find the right answers.
So, what are some ways that medical schools can affect this knowledge gap and this gap, in patient treatment? Developing a culturally competent curriculum is number one, extremely important. Also, working between schools, so having medical students work with social workers and PAs and nursing students, so that that can also help to help bring better treatment to LGBT patients, because it's you are getting input from other professions as well. Having patient panels, come and explain their experiences to medical students, I think is hugely beneficial, as well as journal clubs and workshops to kind of work through current studies and things like that, and that pertain to the population, and also outreach. So Corktown Health Center is the new LGBT health clinic in the city, and we're working with them so that third-year medical students will be able to go through and do rotations with the clinic to help, so that Wayne State can help, so we can help add to the experience and the with LGBT patients. And then we're also working with both Corktown and DMC to do testing there, HIV testing. So we think helping students get more interaction with the community will be one thing that can help to rectify this problem in medical school education. And then,
so we're, not to brag or anything, but Wayne State School of Medicine does do all of these things, or is currently incorporating them into the curriculum. They're going a huge curriculum shift right now. But it's not just Wayne State, it's all over the country. The AAMC, which is sort of in charge of all this, they have official recommendations out there and guidelines to help incorporate this into the curriculum.
So some things we can do to improve the patient experience. We need to increase the amount of research we have, so that patients can, or so that physicians can access current research. We need to make sure that there's a non-discrimination policy in effect. If people are discriminatory, they need to be held accountable. Making sure that patients have gender-neutral bathrooms that they can access. Making sure that intake forms are inclusive, so allowing people to state their gender, also the sex that they were born as, instead of just having a gender box. Making sure that like with parents, instead of asking, the mother and father's name, parent 1 and 2, or those types of things can help so that people don't feel like they, don't feel like, so the moment they walk into the office, that they're being discriminated against as soon as they pick up the form to, to fill in their information. Then making sure that specific literature is available for patients. And we also have to understand the different needs of subgroups. So people of color or people that are of advanced age, those subgroups within the population have different needs.
Some other important things that we need to be conscious of when we're trying to improve the patient experience and improve the healthcare of the LGBTQIA population, we want to make sure that all physicians and staff and everybody who's interacting with patients or not interacting with patients stays up to date on cultural sensitivity training and staying up to date on advancements in LGBTQIA health, so we can continue to provide the best healthcare for our patients. Making sure that our EMR is LGBTQIA friendly, so that stems from the intake forms. So making sure that if you're asking these questions about what's your preferred pronouns or your preferred name and what's your legal name and all of these things, making sure that that's easily translatable to the electronic medical records. And then making sure there's a clear line of referral for complaints and questions. If there's discrimination towards a patient or between coworkers, there needs to be a clear way to report these things and have them dealt with. Incorporating inclusive sexual education and family planning into your practice, and just starting the conversation. In a recent study that was done, 80% of physicians thought that their patients would lie about their sexual orientation when asked, but the patients, when they were surveyed, only 10% said they wouldn't disclose that. So just starting the conversation goes a long way, because a lot of the times your patient will tell you, but it's just a matter of they don't know maybe how you're going to react. So just start the conversation. So we've sort of just given a brief overview of some of the biggest healthcare issues that are happening with LGBT patients and how things are starting to shift towards reducing those health disparities. But there are some extra resources for patients and providers that are out there that I encourage everybody to look at. And then if you guys wanted to talk to us personally, our emails are there. Yeah. So if you guys have any questions. Yeah.
The IA and the LGBTQ?
The intersex. Yeah. Or allies. Yeah.
Any other questions?
Yeah.
But are asexual people considered part of the
Yeah, it's in the sexual minority, we consider it in the umbrella. Obviously, there's different needs and things that every group within every sexual minority needs. So yeah, it's within the umbrella.
And that's part of the problem, is that these things aren't being defined. So when it comes to research and surveys and stuff, these things aren't being asked. So it's hard to know what really is being encompassed when we talk about these things.
There's a lot of stuff about people who are going into practice, but is there anything that's being done about doctors who are already, doctors, like what's being done about people who might not be educated or have their own practice?
Yeah, I can't speak nationally, I don't know, but from the perspective of around Wayne State and DMC, which is what I have the most knowledge of, residents are definitely getting this information. They have to go to seminars and stuff every day, and these things are being incorporated in there. They're having speakers coming in from affirmations and stuff like that to talk about this stuff. And physicians, it's a little harder, especially the older physicians who are stuck in their ways. But that's part of what we're trying to do, is working towards, we're sort of working with the physicians at Corktown to try to come up with ways to reach out into the hospitals and incorporate that. So, Yeah.
Can I just add to that, that the Detroit Health Department and Michigan Department of Health and Human Services have added physician detailers that are specific to like HIV and STD programs. And so a lot of what they're doing is incorporating when they work with physicians is cultural awareness and like taking appropriate sexual histories and all of that into the things that they're working on with them. So hopefully little by little things start to improve.
I'm not sure the reach that the MC has, but would they be able to influence continuing licensure for physicians, like for continuing ed units or something to?
I know what you're talking about. I'm not sure. AAMC is mostly centered on like the medical schools themselves, but there are, and they have their own guidelines, and they're involved in accreditation and stuff like that. In terms of continuing medical education for current physicians, there are options out there, but they're not mandatory by any means. So,
And every state is different.
yeah.
I'm just walking in, so I might have missed this portion, but I know we're talking a lot about physicians in the hospital. Has the, not just physicians in the hospital, but I know, has there been consideration to counseling services? Because I know sometimes there are counselors who are not quite with the program either, but that's your only choice as your insurance is giving you. So has that been considered as well? In psychology or like teaching psychologists?
Yeah, so that is beyond the scope of us as medical students, but we do work, like Ben mentioned, we do some interprofessional healthcare, like it's part of our curriculum to work with other groups like social workers and pharmacy students and nursing students and stuff like that. So the hope is that like we're bringing all these people together to talk about this stuff.
So hopefully as like a social worker, be able to teach medical students, how if they saw problematic language, or just having more or a varied like group of people, hopefully.
And at Corktown Health Center, they do have they have pharmacy coming in, they have caseworkers, they have nutritionists, they have a lot of people who come in who are focused on helping the LGBT population from a bunch of different standpoints.
Are there any disciplinary actions for physicians or nurses who kind of like violate the person's
I don't know specifically. I mean, every hospital is going to be different. Every clinic is going to be different. But it should fall under like an anti-discrimination policy, which and like professionals and all that, which is part of the hospitals, at least around here. That one I don't know. It's definitely